we're trying to train people to think, we're training people to learn, and we're training our students working in a very practical and clinical setting, but we also want to be careful not to intimidate, humiliate, and break. Beta, and then we're moving on.
I think for that, I think that's what simulation is really great for, is for those scenarios when you want to train people, under time pressures and stress. But for the question that you were asking, I like the more one-on-one approach versus the public display. And if it's directed towards a group, then it's just asking the whole group the question as opposed to directing it at one person in front of the entire group.
I think so far, thank you so much. Everybody has brought something up, and I hope that we're sort of either actively or just passively storing these things away to think about the next time you're going to have a student at the bedside, which might actually be as recent as close as 12 noon onward. So away from the Socratic Method, I don't know if I even need to say it, but people have done research on this. I know this from personal experience, but there is research done. If you are a teacher, if you are an effective teacher, you're going to be a better doctor. Period. And this study actually showed just a command of knowledge, not even all of the other peripheral parts of being a good doctor, which means being professional, being present, being respectful, communicating well with patients. This means just the command of knowledge. So what this group did out of the University of Calgary, it was a group of anesthesiology residents, and they were tasked with teaching the entire hospital ACLS. So what they did is they divided them into groups. One group said, hey, you should show up for ACLS. They didn't know that they were going to be teaching. They didn't really do any prep. And then another group, they said, you guys are going to be teaching the algorithms. Study those algorithms because you're going to be teaching them. And then the third group, you said, you're going to be teaching the heart rhythms. So you should study the heart rhythms because you're going to be teaching them. And then they came, and what they did was they said, oh, sorry, algorithm group, you're going to be teaching the heart rhythms. Heart rhythm group, you're going to be teaching the algorithms, and the learn nothing group was the control. And what they found was that at the time, and 60 days later, they both groups had a better command of the topic that they taught, even more than the topic that they thought that they were going to teach. So they studied heart rhythms, but then they had to teach algorithms. And 60 days out, they still knew the algorithms better because they had to teach it. So if you want a better command of the knowledge, it's not the reading, it's the teaching. It's the you generate your own understanding, and then by helping somebody else understand the information, you've solidified that medical knowledge. And if your only priority out of this residency is to be the best doctor that you can be at the bedside, you're going to get better by teaching medical students, straight up. All right. What about the group of us that said, I don't know enough to be the teacher? Like I said, I felt that innumerable times. I'm in over my head. I can barely take care of the patient myself. I can't teach anyone. I don't know enough. So this is a great time for us to think, well, what are my weaknesses? What can't I teach? What can't I teach? Well, it just means what don't I know? So you got to look for resources that help you understand the information, but can also help you teach the information. So this is my shameless plug for the Rational Clinical Exam series. It's put out by JAMA, and it is amazing. Has anybody read any of these articles? We should all subscribe to this. It's free. And read all of the articles. They pose incredible questions. You don't even have to do any work. You'll both learn and teach at the same time. Do opiates affect the clinical evaluation of patients with acute abdominal pain? It is one question posed. The data gathering process, history, physical examination, it's all case-based. And then it shows, positive and negative likelihood ratios of what would make you think this person has a problem, doesn't have a problem. And it shows you, it builds the teaching lesson for you. Read them, they're amazing. My favorite one is, does this patient with dyspnea have acute heart failure? Has anybody read that? No? It's amazing. I'll send it to you all. Okay. Okay, so now let's learn a few tricks. We're going to switch gears. All the sort of over medical education research, which is scary because I'm going to do a 2-year medical education fellowship starting in a month. All right, so let's learn some tricks. So, I read this article. It's sort of loosely based off of like a Gassendi academic. It's loosely based off bedside teaching, sort of. It was published in the Academic Emergency Medicine, and they sort of developed this bedside teaching curriculum, and they wanted to break it down into 10 tips. And I'm going to break those 10 tips down into 6 tips, and I want you to take those away with you. All right. So, number 1, plan your teaching session before your next shift. Huh? This is the emergency department. How do I know what I'm going to see in the next shift? When was the last time you worked a shift and didn't see a patient with chest pain? Come on now. When was the last time you worked a shift and didn't see a patient with abdominal pain or dyspnea? So you need some lessons in your back pocket. All right, so for a very junior learner, we're talking MS1, MS3 early on. What's a good teaching when you see a patient with chest pain? What's something that you could teach an early learner?
Differential.
How to build a great differential diagnosis. Okay, so you got an MS4, they might be interested in emergency medicine, they're on an elective. What's something that you could have in your back pocket about for teaching around a case about chest pain? EKG, risk stratification, okay. Then you've got a more advanced learner, you've got a PEDS fellow. They've seen a whole bunch of patients already with chest pain. They're in the 3rd week of their rotation. And you got a patient with chest pain. What's sort of a more advanced thing that you could have in your back pocket that you might want to teach them? Well, maybe think about less common causes of chest pain and how you could use an advanced skill like bedside sono, bedside echo to augment your learning. These are all tools that we should just have in our back pockets that you can just sort of, you got a patient, you're at the bedside, why don't we build a differential? These are all things that we have, just got to be ready to pull them out and go. So, unlike these handsome fellows on your right, our students are a very heterogeneous group. People come from different places, they have different sets of experiences and different knowledge, all right? So the next team is know your team, know your goals. People just show up, they walk into the ABOT, hey, hi, my name, I'm going to be with you, I'm one of the students, blah, blah, blah. Ask them, what year are you in? Have you done cardio yet? Have you done an inpatient month yet? Have you ever worked in the emergency department yet before? All of these things are going to make us better teachers because you're not going to talk about using a lipid sink for a TCA overdose with somebody who hasn't done pharmacology yet, and they're really just observing your professionalism. All right. And now that we're in our teaching tips, I just wanted to bring us back here. Doesn't matter if you're teaching an MS1, doesn't matter if you're teaching an MS3 or an MS4 and they don't know anything and it's painful. All they want you to have is a positive attitude and be supportive. All right. Tip 3, choose the right time to teach. So this is not going to be the time where you're going to probe your student or probe your junior resident into their understanding of blunt abdominal trauma. It's just not. But it doesn't mean that this isn't a valuable learning moment. What are some of the things that you do, CCT seniors and upcoming seniors? What are some of the things you're going to do to teach around a case like this?
Talk out loud of what you're doing step by step as you do it.
Talk out loud. Great point. It's not obvious to them. It's not obvious that you're doing a primary survey. Call it out loud and say, hey, I'm doing a primary survey. You should learn this. You're learning how to do a primary survey. Tell them you're teaching it to them and then just do it. What else?
If there's a notification, I think it's a good time to, like, what are we setting up for? What do we expect? How can this go?
Good, so what you're doing is you're including the student in your planning. And that's gonna help them think the way that you think. What else can you do in a situation like this? Teaching around a case like this.
You
Teaching.
can always wait till after, kind of debrief, elicit what questions they have, what didn't they understand, the things that they know, the things that they don't know, and kind of try to fill in the blanks.
That is a great point for a variety of reasons, because you can talk through the case and teach them, but it's also important because in a situation like this, they might be exposed to things that are upsetting, new. They might see, this might be the first person that they've ever seen die, and it's really important to engage them and address all of those things as a possibility, as a debriefing, and also to, what did you see, what bothered you, what went well, just to make sure that you've sort of touched base with them to make sure you're not leaving them after the gnarliest code of your life, perimortem C, that's not how we leave our students. Anything else? What other strategies could you use to teach around a situation like this?
A lot of times I'll take the junior side when they're not doing anything. I'll say, watch the senior and see what they're doing right now. See how they organize the case, see how they communicate with other people, and just watch the senior do what they do.
Great.
Assuming they're doing the right thing.
So the junior learner is going to learn a lot from this, whether or not they're all up at the bedside and they know what you're doing and they're calling out the survey with you. Even if they're just standing in the corner. After the critical incident has passed, there are a wealth of teaching points to be made about the situation. Restrain yourselves. Just choose one. Choose one, teach it. Tell them you taught it to them and get them to repeat it. That's it. Move along. And number 4, be realistic. So what does it look like what does drowning look like? Well, for me, it means that I have 7 active patients in the APOD, 5 notes to write, 4 to present, a lap to close, and 2 ready for discharge. Then I have this really hopeful medical student standing right beside me as I'm frantically trying to type a dispo note, and I'm drowning. So we also have a room of patients to see. And I know, well, I'm not gonna ask you to show your hands, I know we've all felt like this. And most of us responded in the survey that you feel like there isn't enough time to teach, and that's one of the things that's holding you back. Just because you have a medical student with you doesn't mean you have to say, okay, you're gonna go see the next patient and do this. No, that's too much for them anyway. It's gonna frazzle your student. Maybe they'll see one patient and you'll do an in-depth discussion about one patient. But when you get to this point where you're just trying to keep your head above water, they can just come with you to the bedside. There's learning that you say, I'm teaching you something and I want you to learn it. Or discussing a medical problem or an exam, physical exam sign. But there are also so many learning opportunities that happen, but you don't even know they're happening by just being there. There's learning that's taught, there's learning by osmosis, and sometimes there's learning that unfortunately you're shamed to learn. This is the time for them to learn by osmosis. Watch them, have them watch you, introduce yourself to the patient. No one's gonna teach them to go up to the patient and say, hi, I'm here to help you, make contact. Those are things that you just learn by watching somebody do them over and over again. So when you're doing this, all you need to do is be the awesome doctor that you are, be compassionate, be gentle, be positive, be helpful, and your student is gonna model just that. Dr. Ahn.
So, thank you, Sally, for saying that. When the medical school education was all this discussion about the hidden curriculum, and I think it's exactly that, it's role modeling. And students hold us accountable to being the best doctors that we know we should be. And I'm as guilty as everybody else in here that some days we have bad days, but you remember you got someone watching you. It's kind of like having a little pair of eyes for those of us with young children, right? They model everything we do, so our students are no different. And, taking them around and saying, let's go discharge this patient, and I want you to focus on how important it is to get the details of this discharge so your patients know what they're supposed to do, right? We can tell them what they're supposed to do, and until we do it and show them how to do it, it's very important. And everything they're talking about. So, that that hidden curriculum we talk about is role modeling. And that's important for us, as well as talking to our consults and everything else. Let's talk to this consult, let's see how it goes. We'll bring them with you to do these things.
Thank you. So be there. Be that bad doctor that you can be. Be the baddest doctor that you can be. And they are going to pick that up. All right, Z, we're tight for time. So tip number 5, be professional. I'm guilty of this as much as anybody else, but this sort of goes along to the hidden curriculum. Introduce yourself, introduce the student to the patient, introduce the patient, and say, hey, this is a medical student. We're gonna be learning together and helping you at the same time. That's gonna prompt everybody to be the way that they should be during that exam. That's gonna identify to the patient that you're taking great care of them. That's gonna identify to the learner that, oh my gosh, I am learning right now at the bedside with a real life patient. I need to learn this. It's setting yourself up for success. Tip 6, summarize and evaluate. It's not obvious. The things that we are teaching our students are not obvious. Summarize. I promise you, you'll hit a note that they didn't get. So, we saw a 26-year-old female with dysuria. All right? We found this, and this on our physical exam. What we found is that dysuria can be caused by a multitude of problems. We found a urinary tract infection. What you did great was, you gathered that urine.
Watch me do that like a champ.
What do you think I could have done better to help you learn, or that we could have done better to help the patient more? Boom. You told them what you wanted to learn, to teach them. They learned it. Move on. And this is sort of above us. This is sort of directed towards our attendings and our leadership. You're going to make a better bedside curriculum in your program if you teach the teachers to teach. So by teaching the teachers to teach, you're going to have teachers that teach. So the moral of the story is, we need to learn how to be good teachers so we can teach the teachers that are going to teach the future teachers. This is us. We are all teachers. Did anyone learn anything today?
Yeah.
Okay. If the answer is no, I don't think so, let's just go through 2 more little teaching points. Okay, a couple little tools to have in your back pocket. A mnemonic, spit. Teach this at the beginning of your medical student when they walk in. Today we're going to practice building differential diagnoses. I want you to spit a diagnosis out at me. So they're going to have to choose something that's serious, probable, interesting, and treatable. Okay? And then that could just be like your little code. Whenever you guys go see a patient, you could say, spit a differential diagnosis. You're going to have a rapport. You're going to have flow. They're going to feel your confidence in them, and they're going to trust you as their teacher. All right. Time to practice. We're going to blow through this very quickly. So here we have a 33-year-old finance guy who presents to the emergency department. It's 2 o'clock in the morning. He's got central crushing chest pain after snorting a giant pile of cocaine. Patient's diaphoretic, appears slightly agitated. He is hypertensive, tachycardic, tachypneic, and mildly hyperthermic. You've got an MS1 in front of you. What's a great teaching point?
Cocaine is bad.
If you want to lose your entire career that you have built, don't do cocaine. Good. 1 more point for an MS1.
Vital signs.
Abnormal vital signs. And I heard sick, right? This is not a well patient. Okay, if you've got an MS3 who's going through their module, what's the next step? What's a great learning point from this case? I feel like that's going to be a common and recurrent theme. Drugs are bad. What else?
The physiology behind cocaine.
Physiology. What about the pharmacology? Does anybody know what it does? Huh? That's a norepinephrine reuptake inhibitor? Okay. I didn't know that. Yes. It causes increased norepinephrine in the synapse. Okay. So an MS4 is going to be, an MS3 is going to be all over that. They've done all their patho. They know this. MS4, good teaching tip. An MS4 on an elective, a visiting student elective who's like, oh, this is so cool. In rural Iowa, we never see stuff like this. What are you going to teach this person?
What are you going to do for the patient?
Pardon?
What are you going to do for the patient?
Okay, talk about management, making a plan. What else?
Thinking about disposition early on.
Disposition planning, right, that's a very advanced thing. It took me well into second year to start thinking about that when I initially saw patients. Anything else?
Don't do it.
Differential diagnosis?
Don't do it.
Beta blockers, this is a good time to talk about that weird beta blocker thing that's always on our shelf and boards and nobody knows if it's a real thing. Okay, so let's move forward from here. I would like to summarize what we've done today and what we've reviewed. Number 1, be positive. Number 2, Dr. G. His voice rings out in my mind way more often than I care to admit. Be nice. Teach to the level of your learner. Don't be a jerk, but Socrates still lives. Be professional and teach the teachers. So before I finish up, I have an especially important point to make. Bedside teaching, like I presented with literature, makes us better doctors. And while preparing this sort of summative talk of my 4 years, I spent a lot of time thinking about the last 4 years, and I spent a lot of time thinking about the last year. I'm going to have to pay for thousands of dollars of therapy to get over the last 12 months. But when I think back at this last year, it's really been a privilege to serve you as one of your chief residents. And I've learned a million lessons. Some were taught to me, some I learned by osmosis, like our junior learners, and some I learned the hard way. Most certainly I learned some hard lessons a very hard way. But the most important theme that came from this introspection is that my priority coming out of residency is to be a doctor. First and foremost,